Good afternoon, everyone, and welcome to our webinar today. Today, we'll be discussing antigen testing in congregate shelter settings, program and implementation playbook. My name is Courtney Pladsen. I'm the Director of Clinical and Quality Improvement at the National Healthcare for the Homeless Council. We are really excited that you could all join us today for this really important topic. I'm going to go over a little housekeeping, and then I will introduce our speakers for today. In case of any technical difficulties, yours or ours, please send us an alert using the chat. If you have difficulty hearing us, if the volume's not wonderful, if things are breaking up, please let us know. We want this to be as impactful as possible. And if you can't hear us, that's not going to work. So please communicate if there's anything we can do to be helpful. This session is being recorded, and the slides and recording will be available to all the registrants within 3 working days, and then we'll post that to our website. And as Brandon shared, please feel free to introduce yourselves. Let us know where you're listening in from, and if there's any particular questions. We want this to be really interactive. So if you have questions throughout, please let us know. Please drop those in the chat, and we'll be happy to respond. All of you have been automatically muted upon entry. If you have a question or you want to share that or come off mute, please raise your hand and we'll be happy to do that and hear from you. We really want you to engage, so please do so in whatever way that feels comfortable to you. And when the presentation concludes, we will have an evaluation, and we encourage you to please respond. We want to always make sure our webinars are the most beneficial as they can be. So we welcome your honest feedback. And the contents and opinions expressed in the presentation are solely those of the presenters and don't always necessarily represent the council. So just want to share that. I am joined today with 3 powerhouses. I am really excited to hear from them today. We have Vanessa Davis, the National Program Lead for Housing from Kaiser Permanente. Elizabeth Imbert, physician, associate professor, clinical lead, so many amazing things that she does. She's in the division of HIV, ID, and global medicine, and really leading a lot of COVID-19 work in encampments and shelters. And Chantel Griffin from the Testing Task Force Equity Lead. So really grateful for you all for lending your expertise to our community today. And please feel free, I know I'm just doing a brief introduction, but I'd love to have you all introduce yourselves a little bit more when it's your time to share. I'm going to now turn it over to Vanessa. Vanessa, you can take it away.
Thank you so much, Courtney. Thanks, everyone. Really looking forward to the conversation. Recognizing, just wanted to say at the top, because this is a smaller group, we really want this to be most beneficial for you all. So we really are going to encourage kind of participation and dialogue throughout. So we will kind of kick off just by framing some things up before we really turn it over to our subject matter experts, Dr. Imbert and Chantel. But I'll just speak a little bit to Kaiser Permanente's work in this space. Next slide, please. So just to kind of kick us off, we'll do a little bit of background and context setting, and then we'll really dive into some more of the detail and nuance of what an antigen testing program looks like for people experiencing homelessness, particularly in congregate settings. So Kaiser Permanente really believes, as you all do as well, that housing and health are directly linked. And we know that homelessness dramatically impacts health. So as a leading health system, we know that we have a responsibility to our members as well as the communities we serve. And that includes the most vulnerable populations, like people experiencing homelessness. We know that average life expectancy for people with unstable housing is 27 years less on average than the average housed person. And we know that overall mortality rates among people experiencing chronic homelessness are 3 to 4 times that of the general population. And the exacerbating, we can go to the next slide, Courtney, thank you. And the exacerbating kind of health impacts of COVID-19, we know have disproportionate impacts on people experiencing homelessness. And Kaiser Permanente has really been on the front lines, of course, responding to the pandemic, and have continued to really accelerate our efforts to not only increase affordable housing and address homelessness, but also address racial inequities and support equity in the communities we serve. So recognizing that homeless individuals are at increased risk of contracting and transmitting COVID-19, we kind of stepped quickly into action with our partners at the National Healthcare for the Homeless Council over a year ago today, in March of 2020, to provide over $1 million of immediate impact grants to 330H homeless healthcare providers, as well as other federally qualified health centers, to really meet the immediate health-related needs of people experiencing homelessness in the early stages of the pandemic. We also pledged and committed $25 million to advance long-term solutions through the state of California's Project Home Key effort to convert and rehab hotels and motels and other forms of housing for supportive long-term housing. That work, also in partnership with enterprise community partners, has provided funding for operational and supportive services for over 1,000 units across the state of California. And then we were also able to provide some core support funds, $6.3 million to over 46 partners across the state, across the nation, really, in our footprint, to really support this coordination among local public health departments, homeless response systems, and healthcare providers amidst the pandemic. Which brings us to where we are today. And over the past many months, in close coordination with Chantel and her colleagues at the California COVID-19 Testing Task Force, we really endeavored to find ways to support innovative and scalable solutions to really expand testing for unhoused individuals and the staff who support them. So this was very much a learning journey for us. We engaged some of our core community partners, including shelter operators, homeless healthcare providers, local and state health jurisdictions, and many others to really understand the current and frankly changing testing landscape and really glean some early learnings and key success factors from testing events for sheltered and unsheltered people experiencing homelessness. And out of that, we really engaged in a very deep partnership with the UCSF Benioff Homelessness and Housing Initiative and the National Healthcare for the Homeless Council to pilot a frequent antigen testing program in shelter settings, which Dr. Imbert is going to speak to in much greater detail in a moment, to really document processes and protocols through the Antigen Testing Playbook, which hopefully you all have seen and have access to now, as well as starting to look for and continue to identify opportunities for additional technical assistance and other support to really scale frequent testing in homeless congregate settings. So with that, we can go to the next slide. We're going to pause here before I turn it over to Dr. Imbert to speak more to the work of the Antigen Testing Playbook and the pilot program. We had a few questions just to get a better sense of where folks are coming from in the audience and what would be most helpful for us to kind of do some deeper dives on. So the first question is popping up now. What are you most interested in hearing about during this webinar? So please feel free to populate your reply. And if it is other, feel free to add in the chat kind of specifically what you're looking for. Hopefully folks are having a chance to access the poll. All right, I think we should we go to the next question? I'm not sure. Oh, there we are, great. Okay, so it looks like the winner here is how to properly utilize antigen tests for screening in a shelter setting. That's great. There's also some interest in preparing shelter sites and staff and workflows. So we can make sure to keep that in mind. Okay, next question. What is your organization's current testing program or regimen? PCR testing only, primarily PCR with some antigen, antigen only, no testing at all. Just really want to get a pulse for where folks are in their communities. Wait another 30 seconds or so. You can celebrate the fact that it's Friday, which hopefully means something for folks. All right, can we see the results? Antigen testing only, okay, about 50%. Then we have a couple folks doing PCR. Someone's not doing any testing at all currently. Okay, great. And I think one more question, I believe, if I'm not wrong. Just a kind of yes, no, and please do feel free to post in the chat, and we'll have some time for discussion at the end. Are you experiencing any barriers in implementing testing within your organization? And please do put in the chat what some of those are. Okay, and let's see the results there. Okay, about 40-60. All right, well, we hope to hear more from folks in the chat about what some of those challenges may be. With that, I will turn it over to Dr. Imbert from UCSF to talk through this work in greater detail. Thanks, Dr. Imbert.
Thank you so much, Vanessa. And thank you to everyone for answering those questions. It gives us a good idea of what would be helpful to everyone on the call. And first of all, just thank you to the council for having us come on and share this work. So a little bit about myself, briefly, I am in the infectious disease division at UCSF, and usually I run a program for folks who are experiencing homelessness who have HIV. That's sort of my work pre-COVID. And then since COVID, I have been overseeing the team that responds to any cases or outbreaks among homeless folks in the city of San Francisco. And today I'm here to talk about our rapid testing program that we ended up implementing in all our congregate shelters. So we have 12 shelters across our city in San Francisco. And we ended up utilizing the Binax Now testing through a partnership with Kaiser and UCSF and our city government and our public health department. And it was very instrumental, and I'm excited to tell you all a little bit more about that. And this was a screening testing program, so testing folks who have no symptoms, just trying to find cases of COVID. So just a little bit of background on this. So as we all know, people experiencing homelessness have high rate of chronic conditions and acute illnesses, face tremendous stigma and discrimination. And there is lack of guidance to implement a lot of the requirements that were required during COVID in some cases. And while we have various strategies for people experiencing homelessness to find cases of COVID, at every sort of step of the cascade that we think about for the scientific response of, finding cases, locating them, isolating them in quarantine, we've really met a lot of challenges and have had to think smart of how to do this best for this population, and then what are the staff and institutional resources that we can really bring to bear, and how do we make decisions about this. So in light of all this vulnerability, really testing became a key part of our response. I think many can remember in the early days, there were outbreaks across all the different shelters, and we were seeing that most folks had no symptoms at all. And so really symptom screening was not adequate. And really testing and bringing testing to folks was going to be a really key strategy to figure out if there was someone in the shelter who had COVID, given this is really a breeding ground for transmission in this congregate setting. And despite this, we before we sort of started doing screening testing in our shelter, which we implemented in San Francisco after, a large outbreak that we had, if we didn't bring it there, we noticed that, these folks weren't always accessing the testing resources that were available throughout the city, whether it was in a clinic or a pop-up site. And then some of the other challenges when we're thinking about bringing testing to folks is thinking about the cost of testing. So PCR versus antigen tests. And then prior to implementing our rapid testing protocol, we were using PCR testing for our screening testing, and that was taking anywhere from 24 to 72 hours to get us a result. And so I think in many times we would hear that the person was positive when we were already behind the 8 ball because they had already gone through, an infectious period, the beginning of their infectious period. You can go to the next slide. So we'll just dive in a little bit deeper of the value of screening testing, which I've talked about a little bit already. But basically, this is really a process to figure out, are folks in the shelter who don't have symptoms, are we able to figure out, are they positive, are they negative? And how do you do this? You do this through frequent, rapid, ongoing testing. So people really know their tests status. Are they positive? Are they negative? And you have to do this frequently. And then rapid testing really allows us to isolate people in real time, as we're getting the rapid testing within 30 minutes. I mentioned this before, but really bringing the test to people was a key strategy and has been a key strategy across the country. Working with people who are trusted messengers, and I'll get into this when I talk about our staffing, but for us, those were the shelter champions that we identified in all the shelters, providing incentives, which is what we did for testing, whether it was food or gift cards, and making this really a collaboration among shelters and public health departments and homeless healthcare providers. And then we talked about the turnaround time. It was really instrumental, the antigen testing, the fact that we could get results within 30 minutes was a big game changer in terms of implementing test and respond rather than test and wait and respond later. You can go to the next slide. So here we're just going to highlight our Antigen Playbook. So we'll give you a link to this later, but through our partnership with Kaiser and with UCSF and with the council, we were able to document how we set up rapid antigen by next testing in our shelters. And this, we did this is because, as much as we see this as a good and key strategy, implementing this is actually really challenging. So taking the concept and then bringing it to other folks, and that's one of the reasons we're here today. And so what we highlight in the playbook, and you're welcome to look at it more online, is some of the barriers you might, anticipate, whether it's staffing or workflow or reporting requirements or CLIA waivers, specifically how you use the antigen testing, how often you want to screen, how you think about it as cases go down or up in your community, and then specific considerations that need to be in place in terms of where will people isolate, how will we respond to cases and outbreaks. So I'm going to go over a little bit of that today. You can go to the next slide. So here are some of the key planning considerations that came up as we were thinking through this. So one first is this needs to be a coordinated effort. So this needs to involve your public health department, the shelter staff, other supporting partners in the community, whether it's homeless service providers. And we had lots of meetings to really get all the stakeholders in play and have them work with us on this. It's really important to ensure, and most places at this point have isolation and quarantine spaces, but you really need places for folks to isolate and quarantine and think about, is that going to be on site or that's going to be off site, and how do you have transport for that? You need a CLIA waiver in advance, and you have to train your staff to, basically meet the requirements for the CLIA waiver. And then you have to ensure that in some cases, and I'll mention this as I go forward, we used confirmatory PCR testing, and that you need to have that set up in advance. The other point here is having a good information management system. And for us, we use Primary Health, which really allowed us to rapidly register people and track people as they tested with us. And then the last thing is ensuring that you have the right amount of tests, the right amount of volume of tests, and be able to replenish those as you're testing forward. And we worked with the state of California on that. You can go to the next slide. So staffing and workflow. Go to the next slide. So here I'm going to show you the initial workflow that we had in the shelters. And so for Binex testing in our 12 congregate shelters in San Francisco, we went there twice a week because it's a lower sensitive test, as most of you probably know. And so we tested twice a week in the shelters. And so when we first started, we had about 3 staff that registered folks on an iPad. They collected some demographics that the state needed. They asked them if they had symptoms and they labeled the card. Then folks would proceed to the testing table where we had 2 staff do the nasal swabs. Then the test would go to the readout table and the tester would add the reagent. We would wait and then we would read the test. And then we had a separate results table where folks could come and get their results. We did have 2 sort of floating individuals on our team. The one on the bottom is our floating nurse. And so that nurse had a few different roles. So one, they were available if people had symptoms and they could figure out in real time, is this someone who's actually a person under investigation? Am I worried they might have COVID, or do they have a chronic complaint and they can stay in the shelter and they don't need to go into an isolation hotel? They also were the ones who always heard about the positive cases and went immediately to go talk to the resident in person, figure out when do they have symptoms or not, determine their infectious period, actually do a case investigation right in that moment, figure out if they had any close contacts or if they'd gone to any other locations, and then make a referral to isolation and quarantine. One piece for the nurse is we were offering testing to staff and residents. So for staff members who turned positive, we would call them on the phone so that they weren't approached in their place of work. And then we would have a phone conversation with them, and then they would report to their supervisor and leave work immediately. The other really key member of our team was the shelter champion. And you can go to the next slide. I'm going to talk more about this role. So this is our workflow once we thought about how are we going to sustain this. So you may have noticed there was multiple steps in our pathway, and there was also many staff members. So in this 8-week pilot period, which we were doing during the surge of cases in January and in February in California, we really had to think about, wow, this is really time intensive and also staff intensive. How do we pare this down? And so a few things that we did. So initially, we took the 3 staff that were registering and the person who was beginning the test and the swabbers and kind of collapsed the roles. So now we have 1 staff that basically registers, determines if the person needs to be registered, because if they're already in our system, we don't need to register them. They figure out if they have any symptoms or not. And then essentially we have people do their own collection. So we have that person pass the swab to the person, this person self-swabs, and then that person adds the reagent and begins the reaction. And then those people are sort of on either side of the person in the middle, and that person in the middle will read out the test. And then we basically collapsed the role of the floating nurse to also be available if people wanted to know positives or negatives and not have a separate readout table. So that's how we did that. You can go to the next slide. Okay, the shelter staff champion was a really key point of collaboration in this project. So essentially at each of the 12 shelters, we identified a full-time staff member, and this person needed to have familiarity with the residents, with the staff, with general shelter operations, and they served as the primary person that the testing team interfaced with when they came on site. We did provide additional stipending for these individuals during our pilot period. And their role is basically, to be the greeter, point of contact with the resident and staff as they arrive for testing, communicating, doing some education on why we're doing testing, helping us develop those communication tools to ensure that they were, meeting the questions and the concerns that people were having. And then they helped us figure out the workflow. How do people proceed through the testing? Where's the best place to set up? And then also they were a real key partner once we had positives who were guests, to help us, figure out where is the room for them to isolate, where can they wait for transport. And so they really ended up being, key partners. And I'll just highlight that these folks have remained key partners as we've rolled out vaccine in shelters. And so I think building on this relationship and this teamwork has been really key. You can go to the next slide. Okay, so now I'll get into the test resulting and action process. So this is the assay that we use, which is the Binax Now assay. It's basically like a card that opens. You drop the reagent, 6 drops. You have to hold it vertically and put that on the little hole that you see there. Then you take the swab, put it in, twirl it around 3 times clockwise, and then basically peel off the adhesive, close the card, and then you're waiting 15 minutes. And really you want to read the results within 30 minutes. We would mark the time on the card. It had a little cheat sheet that's in the playbook of like times and adding 15 minutes to really ensure that we were reading this, within no longer than 30 minutes. You can go to the next slide. And then this is our result action process. UCSF and Diane Havler's group in the Mission neighborhood of San Francisco did really, really great work showing that, the accuracy of the test really increased if you looked at, if it's even a very faint line, but it's going edge to edge, really count those as positive. So how does it work? You'll see a control band. If that's blue, then it's invalid. So you want to make sure the control band is pink. And then you look at the sample window. And if it's a pink line that's going edge to edge, then it is positive. And if it's, a strong line, not a faint line, then it's positive. If there's a faint band, as I said, if it goes to edge, we would still call that positive. And if it doesn't go edge to edge, then it would be negative, or if there's no line at all. You can go to the next slide. So when we first started this, we weren't quite sure what the prevalence would be in the shelters. And so we basically, as as the prevalence is higher, so the more real cases that are out there, the less likely we're going to get false positives. But as the prevalence goes down, the rate of false positives is going to go up. And so this informs some of the decisions we made about who to get confirmatory testing on and who not to get confirmatory testing on. And just to remember, this is all screening testing. So this is not in response to a case or an outbreak or anything like that. This is just screening. So how did this work? If someone had no symptoms and they were negative, then we didn't do anything. We just encouraged them to come back and test with us. And we told them testing was available twice a week. And all testing in our sites was opt-in. If they had no symptoms, but they were positive, then we got confirmatory PCR testing. So the assumption is if they have no symptoms, we're not exactly sure the prevalence, let's make sure this is a true positive. But we did initiate isolation and quarantine for those folks. If they're symptomatic, but they have a negative antigen test, then, and we really think they're a PUI, these are symptoms concerning for COVID, we also got confirmatory testing PCR for those, and we did move them to INQ spaces. And then going down further, if they're symptomatic, but the nurse determined, this is a chronic headache, it's not really COVID-19, and they were negative, then we didn't do anything for them. And that was helpful to have the nurse on site to do this. And then symptomatic folks who were positive, we presumed them positive, and similar to other protocols, we did not do PCR testing, assuming this is a real positive test. You can go to the next slide. So I mentioned this before, but this was really instrumental. If I think back to how it happened, prior to the Binax pilot in our shelters, we geocoded all the addresses of our shelters. So we get notifications that there was a positive result. Then we would try to call the person or call the shelter, then get them to an isolation hotel. Once they got to an isolation hotel, if they didn't have a phone, then we would do a case interview, figure out where else they had been, and do their figure out their close contacts. That would take maybe hours, but maybe days sometimes to do that whole process. And now we're able to test someone, get the result within a half an hour, and then the nurse on site is really able to do that case investigation and contact tracing. And so that was a huge, huge, huge game changer for us to really make the rapid testing team a testing team that can do everything from figuring out if somebody is a person under investigation, referring them to INQ, and then really doing a case investigation and contact tracing to inform sort of the next steps in the case and outbreak response. And this was very, very, very helpful for us, and I think a really key part that we are going to utilize moving forward. You can go to the next slide. Okay, so this is the positive result process for the individual and for the shelter. I talked a little bit about this before. The person's immediately notified, isolated, and we do confirmatory testing if they have no symptoms. And then, you know, what was really interesting is once we had a positive case, our screening testing became case responsive testing. So we kind of, you know, went back through the dorms, got the word out again and said, you know, if you haven't tested with us, there was actually a positive person today, don't want to scare you, but you may want to get tested. So that was really nice. And that is also something that, you know, would take a day or so to set up. And now we're doing it in real time. And some of the things that you probably have considered in your jurisdictions is once you have a positive resident, you know, if they're going to stay in this space, how do you separate them from others? How do we think about testing once we have a positive case? And in our case, you know, we were already doing twice weekly testing, so we just continued that once we had a positive case. And then we would suspend new intakes after we had one case plus a person under investigation or 2 cases. And it's different in every jurisdiction, but these are things you need to think through about how does this, you know, affect the whole shelter. And then obviously there would be a notice that would go up to all staff and all residents, letting them know there was a positive case in your shelter and you should be aware you may have been exposed. You can go to the next slide. Okay, and then I will pass it over to Chantel and I'll take a look in the chat to see if there's other questions, but thank you so much for having me and I'm looking forward to talking more with this group.
Hi all. As stated before, I'm Chantel Griffin with the Testing Task Force. I work directly on community-based testing, which the Testing Task Force has a few community-based testing programs. We found that when we bring testing to the communities and let communities control the testing, we see more consistency and greater outcomes and better outreach and all those other factors when it's community-led. Next slide. So on a really high level, this is just some information on the Testing Task Force, our mission and the programs we currently offer. So our mission is the right test for the right situation at the right time. We understand that depending on whether it's a congregate setting, a place of employment, an individual exposed in community, different testing modalities are better uses. And so right now we have 2 community-based testing programs. We have the Antigen Testing and confirmatory PCR testing program and the PCR testing program. So the PCR testing program has been going on for probably about 7 months now, late November, and it is community run where sites get test kits, they get registration platforms, they get training, et cetera, and run PCR testing for their communities. And so we have a number of partners across the state that use these models. We've partnered with schools, RCFUs and SNFs, municipalities, churches, housing centers, et cetera. So we have found that this testing program is really, with some adjustments, be able to use universally. And about a month ago, we introduced our antigen testing and confirmatory PCR testing. And so just some high-level facts about this one is that the tests are free. We work directly to get the test kits out to you for free. We offer, again, a registration platform. So all the results and demographic information, all that needs to be collected is collected through this. All you need is a tablet. For the confirmatory PCR, we almost in 99% of cases bill insurance directly. And then if someone is uninsured, then we have different funding sources in order to cover that. So there's no barrier to testing and there'll be no cost to the individual or the organization. And then we want to go to the next slide. So this is a pretty high level overview of the antigen testing program and what the state offers, and then what we ask for with our partners who are working with us. So one of the biggest barriers for the longest time with antigen testing was the CLIA waiver. And so we now have a statewide CLIA waiver and a statewide ordering physician. And so when you partner with us, you get access to that CLIA waiver and the ordering physician. So that's no longer something a site or a county has to look for on their own. So we provide the CLIA waiver, the ordering physician, and the laboratory director. We have an IT platform solution, which we're working with Primary right now, where you can enter all the information for an individual getting tested, and then they do the data collection and get it into CalReady and all those things we need to do. And with that also, it is integrated with our PCR program. So if you need to do a confirmatory PCR, you still just use the Primary platform, and it gets the results back to your organization and to the individual to let them know what that confirmatory PCR test result was. We supply the antigen test, and if you're doing the confirmatory PCR, we supply the PCR test as well. Those are shipped directly to organizations so they can begin using them. And we provide ongoing training. We have training, so we also have an Antigen Playbook that is in partnership with the specific playbook for Congregate Shelters. And it goes a little bit more into detail about the trainings. There's trainings that are completed before a site gets test kits, and then we do a kind of, we call it in-person Zoom training, where you actually run a couple of test kits with a trainer to make sure that you understand reading of the test kits and able to provide answers. So when we look at partner organizations, the biggest thing we look for is probably staffing. So if you have staff that are available to get trained on the antigen testing program as well as the PCR. All of the testing are self-swabs, so you don't need to administer this swabs. The individual does it themselves. Then we also ask that if someone is positive in the moment, you give them the results right then and there. And then we have an MOU that you would be required to sign stating that you would use the CLIA and the ordering physician and follow the case use studies for antigen testing. I think for this cohort, the biggest ones would either be pre-entry or surveillance, depending on what you are looking for your community. Both are possible under our current state CLIA, so you can use either option. And then you would also provide on-site confirmatory PCR testing for those individuals who either are symptomatic or who come back positive. So that is pretty high level. If folks are interested, I can give them more information about how they might sign up or what's currently happening, and how to get access to the resources and the program.
Thanks so much, Chantel. That was incredibly helpful. I'm going to just go over a few resources, and then we're going to open it up for a question. I'll stop sharing my screen so we can hear and have a question and answer with all the speakers today. So to access the playbook specifically, you can go onto our website and you can put in your information and download the playbook so you can have access to that. Kaiser is also offering additional office hours, which is incredibly helpful. You can reach out to Tiffany. Her email address is there if you want some additional specific technical assistance around your jurisdiction. They're offering that, which is a really amazing resource. And then for resource for California-based providers, there is interest in becoming a testing partner. You can access that there, testing.covid19.california.gov, so that is there, and then additional antigen testing resources specific to California. So I want to open it up. I'm just going to stop sharing my screen for the moment. And I'd like to ask the presenters to come back on video as well. And love for you all to, if you have questions, please drop those in the chat. So when we think of moving forward and next steps in the pandemic, well, actually all along the pandemic, testing has always been an essential component to comprehensive public health plans. In addition to masks and social distancing, testing has always been essential. We've had the additional added benefit of vaccinations, but testing is not going away. It is going to be important for months and months to come. And we now know that we've seen that infection rates have gone back up. And I can say locally here in Portland, Maine, we have seen another surge of infections, specifically even in our alternative care sites in our hotels and motels for people experiencing homelessness. So unfortunately, we're not out of the woods yet. I'd love to hear, Dr. Imbert, from you, your thoughts about right now where a lot of jurisdictions are having conversations about what congregate shelters are doing, can do in the next few months and year to safely have people come back to congregate shelters. our hope is that we continue to push people and support and use the funding coming through HUD and HRSA to get people into permanent supportive housing, and that we do not go back to pre-COVID congregate shelter levels. But we know that there, in some way or form, shelters will continue to persist. So I'd love for you to share a little bit around how you see screening testing as an essential component to ongoing pandemic response in the next year, as vaccinations continue to be utilized and widely given.
Yeah, I think it's a great question. I mean, I think first off, talking about the capacity, the CDC is still recommending that people have at least 6 feet between heads. And so really thinking about how you're setting up beds and spacing. So I don't think we're quite there yet, although I know there is this desire to increase capacity in the shelters. But I think part of, at least speaking from our city, our shelters have been around 40 to 45% capacity. And we did that through having folks who are 65 or older or who had comorbidities going into the shelter in place hotels. And I actually think that reduced capacity helped us to prevent outbreaks because, there was more space. People actually could do social distancing, which was impossible before when beds were 1.5 feet apart. So just to speak to that, I don't think we're quite there yet. I think keep, looking at what the CDC says and what the state says, and we can think through this as we see vaccination rates go up, both in the shelters, but also in the community. So I think another thing to touch on is when we think about vaccine penetrance and we think about herd immunity, thinking about it just in the shelter doesn't make a ton of sense, right? Because it's not a closed setting. People are going out and working and, being in the community. And so I think we really need, when we think about, do we have herd immunity? Are folks protected? Really thinking critically about how are we going to track vaccine penetrance? How are we going to see if we're getting to 70, 80, 90% in shelters? And then what's happening in the surrounding area? And how likely is someone to get COVID and bring it back into the shelter, whether they're work in the shelter or they live in the shelter? So I think sort of more to come, but I think a lot of the discussions we're having now is how do we really get clear on who's been vaccinated and who hasn't been vaccinated, and as folks come in, how we try to offer vaccines. And I think another thing on that, and sorry, I'm sort of expanding your question because I think there's so many different components, but I will get to screening testing. Another thing is to really, make sure, and we've been, struggling with this through the whole pandemic, which is this is an essential service, right? So when we talk about, vaccine passports, or we talk about needing to be vaccinated, people will never need to be vaccinated to come in a shelter, right? And so all our goal should be getting vaccine penetrance as high as possible, answering questions for people who are uncertain. For the folks who really don't want to be vaccinated, well, then let's try to get everybody else vaccinated. But it will never be that we will require vaccination, for people to come into shelters because it's an essential service. So I think those are all part of the conversations we're having now. In terms of screening testing, I put in the chat, there is just tremendous data that is coming out over the last few weeks showing that, the vaccines are extremely effective in reducing COVID-19 infections, particularly, and if folks get COVID who have been vaccinated, I think we're still learning more, but I think scientifically, we don't really, we don't think they're going to probably transmit forward to other folks. We don't know that for sure. We're going to learn more, but I think, most of our sort of scientific data is pointing to that the vaccines are really effective, especially at preventing hospitalization and deaths, but also of preventing people from getting COVID. So I think that's been really helpful. And because of that, we have decided in San Francisco that if you're fully vaccinated, so you're 2 weeks out from your J&J vaccine, or you're 2 weeks out from your second dose of Pfizer or Moderna, then you don't need to participate in screening testing anymore in the shelters for staff and residents. And we just made that decision just because the data that's coming out on healthcare workers and what we're seeing in the nursing homes really suggests that, you are very unlikely to get COVID once you get vaccinated. And so I think that's been really helpful. The other thing that's come into play as so that's folks are exempt from screening testing if they're fully vaccinated. Now, how we're thinking about screening testing in our city, and every city is every jurisdiction is a little bit different, but we essentially are going to stop screening testing once we get into the yellow tier, which is sort of low case rates. It takes into account equity of vaccination and equity of testing. There's a bunch of different factors, but long story long, it takes into account vaccination rates and cases rates. And so we are actually going to stop screening testing once we go to yellow tier. We're not quite there yet. We are still doing screening testing. But I think it's important to think through these questions. I think, through all of this, it's vigilance, and really being thoughtful, looking at the data, responding to the data. And so I think, I'm just interested to learn more, as we go forward, and just try to be thoughtful and keep people safe, because that's what we need to do. So yeah, sorry, that was a very long answer.
No, it's incredibly helpful. So thank you for all of that detail. I also would just want to point out one of the fascinating things of all of these protocols have been put into place. We've seen record low numbers of flu infections and other transmittable infections within shelter settings. So this is not just helpful mitigating strategy for COVID, it is for other infectious diseases long term. So also really just so many lessons learned from all the public health measures that we put in place. I'd love for Vanessa or Chantel, you to speak a little bit to some of what you've learned from the partnerships, the community partnerships. So I know that a lot of time and effort went into building partnerships between public health entities, with shelters, with health centers, testing, getting on the state level to sign off on those waivers. So I just love all the effort that put into some of this collaboration. What can be learned from all those best practices and translated for other states?
Well, I think from the state perspective, one of the biggest things we wanted to figure out is how to get those resources in communities' hands, right? And so I think what came up over and over and over again, right, was that CLIA waiver. That was probably the largest barrier, and as well as ordering physician lab and all of that. And so, it spent a lot of time, but really focusing on how do we navigate kind of those bureaucracies, get that figured out, and create a program that you could access that and operationalize it at the local level, right? So how do you take the state resource and then move that down to the local level where folks can get test kits, CLIA waivers, access to a registration platform, all of those essential resources that are needed to actually make testing possible. And so we really had to work with local jurisdictions like UCSF and the San Francisco DPH in order to better understand antigen testing and look at how they were operationalizing it, and then use that to develop a kind of a statewide model that can be adapted for folks at that local level.
Thanks, that's really helpful.
I think from the perspective of Kaiser Permanente, we were in a position of trying to kind of rapidly learn, particularly and listen to our local health jurisdictions, our community partners, and really better understand, okay, we have this idea that kind of a multi-layered testing strategy, frequent testing is a good prevention tool to prevent kind of transmission of COVID-19. But we were hearing again and again these sort of recurring barriers and themes around reporting or staff capacity, or and it wasn't necessarily a kind of insurmountable barriers, but they were significant. And so I think in close coordination with our friends at the state level as well, and of course with UCSF, we kind of approach this with like a how might we, right? How might we think about these ways that we can overcome some of these barriers to get this really critical infection prevention and control measure into play. So it was a kind of a very much a rapidly changing landscape, but I think that there were some kind of common themes as we continue to kind of listen and learn, and particularly in conversations with what's happening in California right now, many of those barriers, namely the reporting barrier, the access to testing, the kind of turnaround time, have been kind of worked through. So it's just been really remarkable to see the progress at a state level, and then also kind of in a practical implementation level with San Francisco DPH and UCSF. So yeah.
That's really helpful. I'd love to hear from any of you, any surprises that came out of implementing the playbook, when bringing this to a new shelter and standing up a new program or going through the pilot. What were some of the biggest takeaways in terms of things maybe unexpected, or yeah, just some of the biggest takeaways that you found in the implementation of the playbook?
I'm happy to take a first stab at that. I think one of the things we learned was that folks aren't going to test twice a week with us. So there was like a very small proportion of folks who actually tested, you know, twice weekly for all 8 weeks when we did the pilot with UCSF. And so, but I think that's okay. So during our 8-week pilot period, we still found cases, you know, of positive folks, and the rapid testing and having a team on site that could test and respond was still important to get those folks out of the shelter and into isolation. And we identified, you know, a few small outbreaks, but nothing greater than 5 folks, you know, so it stayed small. And so I think, you know, as we think through this, you know, we really want to, you know, ensure that we are not forcing anything upon anyone, right? This is someone's own personal health decision to test or not test, and we want to make it low barrier and where they're at, and it's still worth it, you know, to test, because you know, depending on the size of the shelter or the size of the cluster in the shelter, you may have to test a larger proportion or a smaller proportion. There's lots of statistics on that. But I think we learned that even though folks weren't engaging in quite the way we anticipated or desired scientifically, it was still okay, and it was still an effective strategy to identify cases and rapidly isolate folks so that there wasn't forward transmission. So that was one of the lessons. I don't know if Vanessa wants to weigh in further.
No, I think that was great. Thanks, Liz.
One of the things that John Guevara was asking about was nurses. So we know that RNs are such a valuable resource and such an integral part of teams in response to COVID-19 and testing specifically, as you mentioned in the playbook. I'm wondering, were those the nurses that you partnered with a public health department nurses? Did you partner with any healthcare for the homeless programs in particular? I know that in San Francisco, HCH is under the umbrella of public health in San Francisco, so it is a little unique, but I'd love to hear a little bit about how you utilize nurses and in partnering with HCH programs specifically.
Yeah, so the nurses that we partnered with were part of the Department of Public Health, and then our like main nurse on our outbreak team is actually from Whole Person Integrated Care, which is the healthcare for the homeless under the San Francisco Health Network. So we partnered with, you know, the health network and the DPH essentially. To the question of, you know, do you need a nurse? So I think, you know, I'll say a few things. It was nice to have a nurse to determine if someone was a person under investigation or not, but I don't think that's a requirement, because I think at this point, you know, we're doing screening when people are coming in. We're over a year into this. If people have symptoms concerning for COVID, the shelter staff, you know, at least in our city, can refer those folks to isolation and quarantine, and they know how to do that. Now, you may get some folks who aren't actually people under investigation, but that's okay. So I don't think you need a nurse. And I think that the role of the nurse to disclose a positive result, to do a case investigation and refer someone to isolation and quarantine, we had it as a nurse, but I think it could be a case investigator or a health worker or something like that. You know, I think we could have thought of that. We did have nurses on our team, so we utilize them in that way, but I don't think it has to be a clinical person.
One of the other interesting things is that HUD went and did a messaging study at 3 different shelters across the country. And one, in terms of wanting to understand messaging, how messaging is being received from people who are staying in shelters around vaccinations. And one of the things that we've heard over and over is that healthcare teams from Healthcare for the Homeless clinics were some of the most highly identified and trusted sources of information. And so building off of those partnerships for testing and then ongoing for vaccination is so important and also effective because they have those established relationships and trust in that location. And often they are doing outreach to shelters on a routine, regular basis. So they may already have that bridge of, we go to this shelter every Wednesday. So they could all utilize that time frame to do routine screen testing. So it's just another way to leverage partnerships that already do exist. But I do think it is fortunate in counties that they are under the umbrella of public health as well. It just happens to be a great partnership. And we hear that out of Hennepin County as well. So there are lots of great jurisdictions that have those embedded partnerships as well. Just wanted to also,
Sorry,
oh, go ahead, please.
I was just going to say that I think the partnership abilities are amazing, but I also want to acknowledge, even in California, we have so many regions that don't have those kind of partnerships available. And so one thing we really wanted to make sure with our state program was that we had a lot of technical assistance in order to help folks who maybe don't have that clinical background or don't have have never had experience with testing, have a lot of ongoing technical assistance. And so one way we did that was to develop we have cohort leads that work directly with different organizations that have more background working with those organizations. And then we work with our testing vendors, such as Primary, to have ongoing trainings, ongoing office hours. And then that way anyone can contact someone, whether it's with Primary, it's with the state, it's with their cohort lead, to get more information to figure out how to set this up, even if they might not have those resources available in their county or region, because we really just wanted to make sure that, we have counties that the SF that are great. They have so many resources, so many intersectionalities, but, we also have those other programs that in other regions that need the ability to have additional supports but still have access to testing.
Helpful. And John, just to answer your question around as INQ is scaling down and routine testing being part of strategies in response, I've also seen, and I know in my own community, we leverage community health workers and medical assistants to do the antigen testing. So we know that other team members who have been trained can also be partners and do the testing as well. One thing I wanted to call out that we haven't said explicitly, but has been an undercurrent of so many of the comments, is that I see screening testing as really another piece of equity, and the way that it's being done in these settings. It's decreasing barriers to care. It's bringing testing and necessary resources to the communities where folks need it the most. And so I just want to call that out. It's really a lot of the work that is being done is really through this lens of health equity and really trying to prove health outcomes for people experiencing homelessness. So really appreciate all the work that you all are doing to really try to improve health outcomes for people experiencing homelessness. We just have a few minutes, so I just wanted to wrap up and just really send a deep appreciation for all of the work that you are doing in California specifically. I know that's where you're all based, but I know that this playbook is going to be utilized nationwide. So really appreciate all the effort and time that you put into this. Also just wanted to share with everyone listening that next week we're continuing our webinar series on trust and trustworthiness. And really, we got into this conversation saying, when thinking about how we promote vaccination and engagement in our health centers, we really wanted to take a look inward and say, how do we as healthcare providers, at Healthcare for the Homeless and shelter providers, really examine ourselves to make sure that we are building trustworthiness and that we're deserving of our clients' trust. And we had a really wonderful conversation last week, and we're continuing that next week. So we just want to welcome you all to join us for that. And Brandon just dropped a link for that in the chat. So thank you all for your time. And please reach out for office hours, for additional technical assistance through the website shared. And please reach out. We're happy to be ongoing resource in this work because we know it's not over. So thank you all for your time, and just deep appreciation to Liz, Chantel, and Vanessa. So thank you all so much. Hope you have a wonderful weekend.
Thanks, everybody. Thanks, Courtney.